Vermut Annual Genetics Ethics Lecture. I'm Dr. Clarence Braddock. We'll get started in just a moment. Just give a moment for folks to stream in the digital doors, and then we'll begin. Well, it looks like the number is plateauing. I'm sure we'll have others join. So again, welcome. I'm Dr. Clarence Braddock, Executive Vice Dean and Vice Dean for Education at David Geffen School of Medicine and Interim Director of the UCLA Health Ethics Center. Delighted to welcome you today to our annual genetics lecture. It's my great pleasure to introduce our speaker today. She is Emily Largent. Professor Largent is the Emanuel and Robert Hart Assistant Professor of Medical Ethics and Health Policy at University of Penn, Perelman School of Medicine. She holds a secondary appointment at Penn Law and is core faculty member in the Penn Memory Center and Penn Program on Precision Medicine for the Brain. Dr. Largent's work explores ethical, social, and legal issues arising from Alzheimer's disease research and care. Some of you may recall Dr. Largent from her time here at UCLA, where she was a nurse in the CTICU and well known to many members of our community. And it's a great pleasure to also welcome her back, albeit in a different role now. Dr. Largent studied science, technology, and international affairs as an undergraduate at Georgetown and earned a second degree in nursing from Penn Nursing. After working here, as I mentioned, in the CTICU, she went on to receive her PhD in health policy with a concentration in ethics from Harvard University and her JD from Harvard Law School. Dr. Largent previously served as a fellow in the Department of Bioethics at the National Institutes of Health and also clerked for Chief Judge Jeffrey Howard of the U.S. Court of Appeals for the First Circuit. We're delighted to have her here today to give her remarks on the topic, Mom's Genes, Genetic Testing, and Alzheimer's Disease. Professor Largent.
Thank you so much for the gracious introduction, Dr. Braddock. I'm delighted to be here. As Dr. Braddock said, I was a nurse in the CTICU, and I have to say my ethics career really started there at the bedside. And although I have pivoted away from the bedside, everything I do is informed by the patients I cared for at UCLA and the experiences I had there, and really trying to appreciate that the work that I do hopefully is informing what's happening at the bedside to make experiences better for patients, for families, and for the clinicians who care for them. I know really what a difficult and important role that is. And so I'm so pleased to be here today. So I will be talking about genetic testing and Alzheimer's disease. And just by way of disclosure, I do have grants from the National Institute on Aging and the Greenwall Foundation, but all the views that I'm presenting here today are entirely my own. So as a roadmap for what we'll be talking about today, I'm going to talk a bit about why current clinical practice guidelines recommend against APOE testing. APOE is a susceptibility gene for Alzheimer's disease. I will describe a bit how individuals react to learning APOE test results and contextualize that in what I think will be a revolution in clinical practice, where we will soon be disclosing these results much more routinely. And I will also have a little grab bag at the end of what I think are some important ethics and legal issues that we should be anticipating as this testing becomes more widespread. So just to make sure that everybody's on the same page as we get started, it's important to realize that dementia is a general term that describes a loss of cognitive functioning, so thinking, remembering, reasoning, and also behavioral abilities to an extent that interferes with daily life. So in the beginning stages, when somebody has mild dementia, this might just be minor interferences with their daily life, but as they get to the severe stage of dementia, this can mean that they require assistance with the basic activities of daily life, including feeding, bathing, dressing, grooming, and toileting. Now, dementia, while it is common in older age, is not part of normal aging. And when we think about dementia, it can have numerous causes depending on the kinds of changes that are occurring in the brain. So the graph that we have here shows you that Alzheimer's disease is the most common cause of dementia. It accounts for about 2/3 of cases, but you might be familiar with other causes: vascular dementia, Lewy body dementia, frontotemporal dementia, and others. And it's not that unusual for individuals to have mixed pathology where they have more than one of these things happening in their brain. Now, when we think about Alzheimer's disease, it's really important to realize that it's quite feared because of its effects that it has on autonomy and self-determination. It's not unusual for people to describe it as a fate worse than death. And it's also a highly stigmatized condition. And we know that the stigma that's associated with dementia can actually be a real impediment to seeking care, both for the individual patient and also for their caregivers. Not only that, but the stigma that's associated with it will increase oftentimes the burden associated with caregiving, even beyond what would be expected of the emotional and physical labor that's associated with caregiving. So that's a really important aspect of all of this when we think about disclosing APOE results. Now, there are multiple known risk factors for Alzheimer's disease. One of these includes genes. Now, there is no deterministic gene for late onset Alzheimer's disease, that is Alzheimer's disease that comes on after the age of 65, but APOE is a susceptibility gene that's often discussed in this context. There are 3 alleles that we talk about when we talk about APOE. So E2 is relatively rare and it's thought to be protective. APOE3 is the most common allele. It's treated as having a neutral role in causing Alzheimer's disease. And then there are the E4 alleles, and those increase risk, and they're associated with earlier onset of late onset Alzheimer's disease. And those kind of, in terms of common occurrence, are between E2 and E3. Now, if we have genetic testing, that can tell us what APOE alleles an individual has, but APOE E4 alleles are neither necessary nor sufficient for somebody to develop Alzheimer's disease or the dementia that we associate with that. So, we know that some people develop Alzheimer's disease even though they don't have any E4 alleles. Some individuals have E4 alleles and will never develop Alzheimer's disease. This is an area for further research. So we have this information, but I have to say that it's not common in clinical practice for APOE testing to occur or for those results to be disclosed. So here we have a headline from Kaiser Health News where, the headline, right, speaking to that fear, to the stigma that I've talked about, stalked by the fear that dementia is stalking you. And over the course of the article, we have this quote that comes up. I spoke to half a dozen experts for this column. None was in favor of genetic testing except in unusual circumstances. So why do we have this gene that we know introduces risk, and yet it's not common for us to see it being recommended clinically? And I would say that's just, there's this perception that it's generally thought to have fairly limited clinical value at this point. So it really speaks to only part of an individual's risk for developing dementia or mild cognitive impairment caused by Alzheimer's disease, right? The neither necessary nor sufficient aspect I talked about. Risk reduction measures are the same for everyone, whether or not you have an E4 allele. We know the World Health Organization a few years ago recommended healthy lifestyle, so diet, exercise, getting good sleep. That doesn't change whether or not you're an E4 carrier. After the onset of symptoms, you can't use an E4 allele to make a diagnosis, right? You still need to think about other aspects of the neuropathology there. And additionally, after diagnosis, the clinical recommendations have not historically depended on your APOE status. So we can see it doesn't inform the diagnosis or management of the disease. And so generally, both professional guidelines and the National Institute on Aging have recommended against it. And as a result of this, it's also the case that insurers typically don't cover it. So we're in a situation where there's very little incentive to provide it. But Alzheimer's disease is going through just a scientific revolution right now. It's an incredibly exciting moment to be involved in Alzheimer's disease research and care because we are seeing this huge transition where we're moving away from having a very syndromal-based definition of Alzheimer's disease, where we diagnose people based on how they present in clinic, to having a biologically based definition driven by biomarkers. And while genes are not part of the diagnosis of Alzheimer's disease, they have a role to play in this scientific transformation. So I think this is seen most clearly in the context of FDA's recent and very controversial approval of aducanumab. And this is likely going to increase demand both for amyloid testing, right? So amyloid is one of those Alzheimer's disease biomarkers, and aducanumab is an anti-amyloid drug. It's supposed to clear that out, and hopefully, we don't have great evidence of this, but hopefully it's going to slow or prevent the onset of cognitive impairment, but also APOE testing. And that's because if one is an E4 carrier, right, if they have that allele, it increases their risk not only of developing Alzheimer's disease, but if they take aducanumab, of developing what's known as ARIA. So that's the amyloid-related imaging abnormality, and that can be bleeding or swelling in the brain. So this is an example of an effusion related to that. And so while it's not on the FDA approved label, this was part of the controversy, it's generally thought that APOE testing is going to be important before prescribing aducanumab to patients because it will help us stratify their risk of developing these adverse events. Now, for those of you who've been watching in this space, there has been a lot of pushback. So FDA had the accelerated approval of aducanumab, and we've seen that, perhaps most dramatically, the VA came out and said they would not be providing it for veterans. But already FDA has signaled that it has opened the door to other drugs. Eli Lilly's already submitted an application. So if it's not aducanumab, it's going to be something else. And we're going to have increasing pressure to bring APOE testing into the clinical space. Okay. So just to pause for a moment and think to yourself, is your APOE genotype something that you personally would want to learn? And you can think just for a moment about why you would or wouldn't want to learn that. Okay, so let's see how you compare to others. So in surveys, we've seen that desire for APOE testing is actually quite variable. About 3/4 of adults say that they would take what's called, what's described to them as a perfectly predictive test for Alzheimer's disease. If there was a test that would tell you, yes, you will, or no, you won't develop dementia caused by Alzheimer's disease, 75% of people say that's something I would take. Now, of course, what I've described so far with APOE is not a perfectly predictive test. Rather, it's more akin to the second bullet point I have here, which is a partially predictive test. And what we see is once you describe a test as somebody as being partially predictive, only about half of people indicate that they would be interested in receiving information like this. So the next question I have for you is, if you did learn your APOE genotype, what do you think that would be like? What would the experience of learning that you had a brain at risk be? So I'm part of the team at the University of Pennsylvania that's actively been trying to understand what it is like to learn that you have this APOE genotype, whether that's that you're an E4 carrier or you're not a carrier, so that we know more about the experience as we anticipate these momentous transformations in clinical care for Alzheimer's disease. So what we have done is we've taken advantage of a feature of many prevention trials that are ongoing, and that is that they test participants or prospective participants to better understand their APOE for their genotype, and that's to both enrich the sample for the study, because over the course of the study, right, if you're trying to see if a drug prevents or delays the onset of cognitive impairment, it's important that you have people who are at risk for cognitive impairment. So having E4 carriers can help you kind of get to that sample that you're looking for to test the outcomes of interest. And as I already said, it can also influence the risk of being in the study. So it's part of the consent process that you need to tell people what kind of risk they're going to be at. So because this testing is happening and the results are being disclosed to individuals as they screen for trials, our team has been able to partner with researchers to interview their research participants about the experience of learning their results. So in the SOKRATES II trial, the study of knowledge and reactions to APOE testing, we talked to individuals 3 months after an APOE disclosure, and then again 12 months after that first interview. We were able to transcribe and code those interviews, and I'll be presenting those results to you today. So it's important to realize, just as background, that individuals who participated in SOKRATES II went through a standardized disclosure process as part of their participation in the API generation program. So they were able to meet with a genetic counselor to learn those results, and they learned those via various modalities. So some learned them via phone, some via video conference, and some learned them in person. Now we have some studies that I am not personally leading, but that looked at sort of how happy people were with the different modalities. And while some people do have a preference between them, most people felt relatively indifferent about how they learned these results. Much of the emphasis was placed rather on what they learned. And here are the risk estimates that we gave individuals in terms of their chances of developing either mild cognitive impairment or dementia caused by Alzheimer's disease. So our E4 homozygotes were told that they had a 30 to 55% chance of developing MCI or dementia. The heterozygotes were told it was 20 to 25%, and the non-carriers were told, consistent with the population average, that their risk was 10 to 15%. So one of the strengths of our study is that oftentimes, given that the E4 alleles are relatively rare in the population, studies that have looked at APOE disclosure previously haven't really had a lot to say about homozygotes, but we enrolled 19 in this qualitative study. We had 31 heterozygotes, and we had 20 non-carriers to serve as a comparison group for this. Now, I do want to say, while I don't have a demographic slide up right now, that these tended to be relatively affluent individuals. They were almost entirely white, highly educated, and many of them had a family history of Alzheimer's disease. So I would encourage you as we go through to realize that's a limitation. But I will say that the participants we recruited are quite reflective of the individuals who participated in the API generation program. And what this really speaks to are larger concerns about representation in Alzheimer's disease research. So we know that this is a condition that disproportionately affects members of the Black and Hispanic populations, and yet they are underrepresented in trials. So I've already mentioned aducanumab at several times now. And what we know is in those studies, which Biogen used as the basis for their submission to FDA, that they had 11 Black participants and they had 1,300 white participants. And again, that's important to put that against the backdrop of a disproportionate burden in the Black and African American community. So important area for future research, especially as we think about this moving into clinical practice. We need to be able to further contextualize these results in terms of understandings of dementia, what it means in terms of normal aging, family care systems, and these broader support structures. So there are some really key questions that we can answer at the outset about APOE disclosure with those caveats I just provided. So one is that disclosure is generally safe. This is sometimes offered as a reason why we shouldn't disclose, and that's that if we tell individuals that they're at risk for dementia or mild cognitive impairment, that they will experience depression, anxiety, or suicidality. And in our samples and in others, this has not been the case. Now, these are pre-screened populations. We have had some people that we have excluded at our center from research because they call in, they say they'd like to participate in studies, learn their risk, and that they would potentially use that information to inform a decision, say, about committing suicide. But at least in these pre-screened populations, this is not devastating information, even if it's emotionally difficult information. Another concern that's often cited in the literature is that it's too difficult to convey this very probabilistic information to individuals, that they won't understand because it's not, a deterministic gene, rather it's susceptibility. But what we've seen is that with appropriate education, we do pre-testing education, and then we do disclosure with further education wrapped around that people do tend to understand the implications of the results for their personal health and well-being. Now, it can be a little bit difficult sometimes to parse out how well they understand, because they tend to say things like, maybe you're an E4 heterozygote, and you might say, well, I'm at decreased risk relative to an E4 homozygote. So you really have to listen to where they're comparing, but most people, they do walk away with an appropriate understanding, even if they choose to frame it in ways that we might think support their emotional well-being upon the receipt of bad news. Now, what we find in talking to individuals, they tell us that APOE results are not like other medical test results that they've received. And there are 4 key reasons driving this. One is that these results are particularly emotionally fraught. So I mentioned at the outset that dementia is seen as a fate worse than death, and people really speak to that. This is a very feared diagnosis. And so while this is not diagnostic information, knowing that they're increased risk says, well, it's just heartbreaking when somebody has Alzheimer's disease, because the person, they're just gone, right? So they have it all wrapped up in these ideas about identity and what it means to really live in an engaged life. And so this is very emotionally fraught. They talk then about implications for relationships, right? So Alzheimer's disease has a stigma around it. They don't want people looking at them and feeling sorry for them because they found out that they're at increased risk. People talk about the uncertainty, right? This is a point that I've tried to already hit upon multiple times. right? This is not definitive that you're going to develop Alzheimer's disease. There is an increased risk, but it's uncertain. And if it happens, it could be years or even decades into the future. And the final thing people talk about is the lack of medical actionability. So if you had insulin, or if you had diabetes, you would take insulin, but there's no comparable intervention if you find out that you are an APOE4 carrier. Now, I talked about the safety piece, right? We know that people aren't experiencing clinically significant levels of depression, anxiety, or suicidality, but that shouldn't overshadow the fact that there is extreme emotional variability after people learn their results. So when we talk about the non-carriers, right, people who don't have an E4 allele, they're pretty straightforward. I don't know how many of you have done qualitative research who are here with us today, but this is the kind of coding that's quite easy to do because almost everybody to a person uses the words relief or happiness. So we have here somebody who says, I was relieved and teary, and she tells the interviewer, I'm tearing up just thinking about it again because the relief was so overwhelming, right? People very happy not to find out that they don't have an E4 allele. Carriers, though, have a much more variable emotional response. Unsurprising, I think, to many of us, they can talk about negative emotions, sad, worried, depressed, but many of them speak to having positive emotions about this process as well. They talk about how important the information is to helping them plan ahead and to feel empowered in their futures. And so while they recognize that it's not medically actionable, this doesn't mean that it's not personally actionable in other ways that I'll speak to in another slide. There are many people who have mixed reactions. Rarely are things all good or all bad. And then there are those who are neutral. They just talk about accepting it. It is what it is. Now, I'll say that over time, we had those time 1 interviews. People often spoke about having positive or negative or mixed emotions at time 1. But by time 2, as in other genetic conditions, we really see this regression to the mean. People go back to this baseline state and they talk about being much more neutral. So while maybe initially they talk about feeling angry or upset, now they've gone through the stages of grief, as one person told us, and they've just accepted that it is what it is. Now, one caveat we have to have in this is that APOE testing is rarely done in isolation. We know that there are other factors that are going to influence how people respond to this information on an emotional level. And we've seen this in terms of people who are undergoing amyloid testing, right? So amyloid is one of the biomarkers of Alzheimer's disease. We talk about amyloid, tau, and neurodegeneration. The ATN framework is how we can think about the biomarkers of Alzheimer's disease. And in many of these studies, people get an APOE result, and then they might also need to have amyloid testing. And they have to make sense of those pieces of information together. And so for some people, right, it's quite reassuring to find out that you're an E4 carrier, but you don't have any amyloid. People then feel like that dials back the risk. It dials back the concern that they have about being a carrier. Now, for people who find out that they have elevated amyloid, they will often then be eligible for a clinical trial. And this is this picture of the pills I show, although most of these are injections right now. But people are willing to learn these results when they feel like there's something they can do. They want to feel like they're learning and then acting. And so the ability to participate in a trial can be very, part of that sense of empowerment because they have the risk information and now they can do something about it. Now, for anybody who's worried about therapeutic misconception, since we know that we've had so many failed trials, unfortunately, in this space, people recognize that. They know that they might not benefit themselves. They know that the trial might itself have negative outcomes or findings, but they feel that if they can't help themselves, at least they can help others. And we've had a few people who find out their APOE results, then they find out on other grounds that they're ineligible for the research. So there was an individual who was a transplant recipient, but they had already learned that they were an E4 homozygote. They talked about having really dark days because they couldn't participate in the trial. They felt really powerless now. They had this information that they felt was really bad information and nothing that they could do about it. So as we watch this space going forward, we'll need to think about how it interacts with other risk information and how the ability to take a treatment or participate in a trial mediates emotional reactions as well. So something else that's interesting in this space is that learning an APOE result can actually change how people perceive their own memories. So for people who find out that they're E4 carriers, many of them talk about how this either validates baseline concerns they have. And this is really interesting given that we were testing people, right? We were interviewing people who were cognitively unimpaired on clinical testing, but they already had subjective cognitive complaints. And so for them, finding out they were an E4 carrier validated their concerns, or it actually introduced new concerns. And people talk about, I didn't remember my employee identification number, and I wonder, is this how it starts? Right? There was a lot of this. Is this what it feels like? And that's the quote that we have here. Somebody says, when this little blip comes up, I think, oh, is this how it happens? Now, non-carriers typically felt very reassured once they found this out. They talked about reinterpreting slips and blips as signs of normal aging, right? They'll laugh and say, now I know that's just who I am. Not, it's a senior moment, nothing to get too worked up about. Now, there are very few people who continue to have subjective cognitive complaints. They find out they're non-carriers, and they actually express a pretty deep frustration that they feel like they either shouldn't be having these problems, or they feel like they're still lacking an explanation. So we'll need to think about people for whom this isn't the end of the diagnostic journey, but rather a start once they're getting this information. Okay, we talked a little bit about empowering. Why is it empowering? It's because people are using it to change their health behaviors and their future plans. So in terms of health behaviors, people talk a lot once they find out they're carriers about increasing their exercise, they're running more, they're doing yoga. They are changing their diets. I have read whole transcripts where people talk about how much they despise fish. They don't like the texture. They don't like the smell. They don't like any of it. And now they're eating it twice a week because the omega-3s are really good for their brains. So people are willing to take that information on board to change their diets. They're also playing brain games, trying to remain socially engaged, doing things they feel might modify their risk. Now, it's not to say that non-carriers don't also change their health behaviors when we've talked with them over the course of a year, but they tend to describe it not in terms of modifying Alzheimer's disease risk, but say just working on getting stronger, losing that last few pounds. Future plans is where we see a very interesting divide. In terms of our E4 carriers, we see that they are trying to use this information now to plan for a future in which they face the prospect of cognitive decline. They make financial changes, revising wills, trying to sell things and manage property. They start to make very interesting trade-offs between work and retirement. So on the one hand, they see work as very important for earning money and trying to save resources for future care needs, right? We know we have a national over-reliance on informal caregivers, and that it can be very expensive to care for somebody who has dementia. So they feel like they need to save money. Some of them also speak to the potential cognitive benefits of being in the workplace. But at the same time, they wonder if they should retire earlier, move those timelines up, because they would like to be able to go out and check things off the bucket list while they're still able to do that, right? They want to visit grandchildren, they want to travel, they want to do things while they are still cognitively able to do so. Non-carriers, by contrast, they actually talk about having a more expansive sense of the future. They feel like they have more time, more space. They can plan ahead with more confidence because they don't have this worry lingering in their mind. They're going to experience cognitive impairment. Monitoring, I think, is an area for potential opportunity. Some of our E4 carriers talk about how important it is to ask others to start to watch them for incipient changes in their cognition. They want people to look over their shoulders, tell them, am I repeating myself? Am I forgetting things? Keep me honest if you realize that I'm trying to do this. But others, right, so some of them want monitoring. Other people feel like that's incredibly intrusive. They're not cognitively impaired right now. They feel like it's an invasion of privacy. They're not interested, even if their family members think that they would like to do that. So potential point of tension. And I think this is an area that's only going to become more important as we gain more and more ability to monitor people, not just through our interpersonal interactions, but through mechanisms like, tracking people's driving. So there have been some studies lately that we're actually able to see that people, well before the onset of cognitive impairment, they stay closer to home, right? They limit their driving routes. We see that people start to maybe miss some payments and do things in their finances before the onset of like clinically measurable cognitive impairment. There's also a lot of interest in different phone apps that can track gait or speech patterns and perhaps help with the process of ascertaining risk. Okay. So obviously, we know that this information is being given not to just to an individual, but it's actually being injected into a family system. And so it's worth pausing and asking yourself how you would feel if, say, your partner, a parent, sibling, or other individual who was close to you shared their APOE result with you, right? So now you're not learning about yourself, you're learning about somebody that you care about. So we've had studies where we've been able to do this too. A very interesting feature of Alzheimer's disease research is that many times people are required to enroll not just as themselves, but as part of a dyad where they have a study partner. Now, the study partner is an individual who comes in and they can give the researchers information about the individual's cognition and functioning that both help establish eligibility for a study, right? If you need to be cognitively unimpaired, they can inform that assessment. But additionally, they can offer information that helps with outcomes. Study partners also have an important role to play in making sure people adhere to their study therapies, that they come in for visits. They often help with driving, right? They have these very broad roles in individuals' lives. And so, again, taking advantage of the features of the research, we interviewed study partners to say, what's it like to learn? And most of the time, study partners are a spouse or a sibling or an adult child. So for what we found in this group is that oftentimes the understanding of risk tracked what we saw in the individual participants themselves. So for people, in terms of the emotional reaction, those who are at increased risk talk about sadness, disappointment, worry, right? Sad for me, sad for him. Whereas people who found out that their loved one was at average or decreased risk talked about relief and happiness, those same words coming up again. We also saw changes in health behaviors and future planning in these individuals. So the health behaviors were interesting because people who found out that their loved one was at increased risk often talked about changing their health behaviors because they wanted to be better caregivers in the future. Again, anticipating this future of cognitive decline, they decided that they needed to make sure that they were physically healthy and well so that they could provide care. And in terms of future plans, I think for people who have close relationships, we know that we often envision our futures as very intertwined with the people that we care about. And so when they saw that the future sort of trajectory of their loved one maybe that was changing in light of the information that they had, they changed their own. They moved up their own timelines. Maybe they considered retiring earlier themselves so that they too could be part of the bucket list activities and think about things. Or they felt freer to make plans, right? Many of these couples that we were talking with, they knew they had a family history of Alzheimer's disease. They had been thinking this was likely going to come for them. Finding out that there was not an E4 allele meant that everybody felt somewhat freer in planning for the future. Now, the other thing that was interesting to us is that we know that people can sometimes share health information, including APOE results, with others in their lives because they see it as being relevant to the recipient's health. That, in fact, motivated a lot of sharing when we talked about that. That was a focus of yesterday's lecture at Cedars-Sinai. Why do people share this health information? And for people who were E4 carriers, many of them said that they had told family members because they saw it as important to the recipient's health, and they wanted the individual to go ahead and get tested. They had shared information about testing. Many of them talked about using 23andMe because they knew they couldn't do it clinically, which of course, this direct-to-consumer testing always raises its own interesting ethical questions. But they felt that it was important to share because they had passed it on maybe, or they had shared familial risk factors and they wanted people to know. That being said, it was often the case that family members were not that interested in getting tested. Some did, but even amongst people who were, say, an adult sibling of an E4 homozygote, they didn't want to have it happen. We had a few people who had gotten tested, got right up to the moment of disclosure and decided they weren't going to find out the information. So again, when we think about how genetic information very particularly can communicate risk, not just about the individual who receives results, but the people around them, this is another area where we know, given all the context, people might not be so interested. So I do think there are a number of challenges ahead on the road, given everything that I've said, and I'm going to take a few minutes to walk through these. So the first of them is the 21st Century Cures Act, and I would assume that UCLA, much like the Penn Health system, has really been grappling with how to implement the requirement in the 21st Century Cures Act that we give information electronically to patients rapidly. That includes notes, test results, and other things. So if we are going to have APOE testing more widespread in clinical practice, how do we think about giving people that information back? Now, a key part of the 21st Century Cures Act was try to overcome medical paternalism and enhance patient autonomy by giving them rapid access to information that was important to their health and well-being. Now, that being said, of course, we have a few very interesting things happening in the context of APOE, right? We have clinicians who are not used to ordering it or delivering it. We have the sense that because of the nuance related to, that it's a susceptibility gene and not a deterministic gene, how do we communicate that to people? How do we think about education, right? It's part of my philosophy is that we're not empowering patients just by giving them information. They have to understand that information and they have to know how to use it in ways that are consistent with their values, their interests, and their well-being. So I think in this space, we really do have to think about offering things in terms of plain language results so that people can read it and understand. I have a colleague who's joked about Alzheimer's disease biomarkers, right? So that amyloid, tau, and neurodegeneration, that we have this expression, it's Greek to me. And in this case, it is literally Greek. So when we give it to people, we need to serve as translators. We need to think about how to communicate this information with them. And so I would advocate that in addition to the plain language summary, we need to think about having self-directed educational materials. These should be standardized and available through professional societies or ideally the NIA so that people can go and find out from a reputable source. They have standardized information to hopefully help address health disparities given uneven access to, say, genetic counselors or people with expertise on APOE. And we really need to think about what tools should be in place once people have that so that they can live again, and act consistent with their values and interests. Another thing of great interest in this space is to think about direct-to-consumer genetic testing. So for a very long time now, or at least for a few years, 23andMe has offered direct-to-consumer APOE testing. It was actually not too long ago that I was in the middle of a meeting and my phone buzzed, and there was a picture of a friend's results, and she had found out that she was an E4 homozygote and had texted me to say, well, what do I do about this now, right? And so there's a reason why it's long been controversial that 23andMe is disclosing this to people. Again, all the context and background that I've talked about. And I would say that we're on the cusp not just of more direct-to-consumer APOE testing, but we have to think about how direct-to-consumer testing is soon going to encompass other aspects of Alzheimer's disease risk. So there's a lot of interest right now in the development of blood-based biomarkers. At present, we can use MRIs, PET scans, CSF, and that can tell us whether or not people have the pathological changes associated with Alzheimer's disease. And blood-based biomarkers are going to offer for us a less invasive, less expensive means of finding out and ascertaining if people have these same biomarkers. And I've argued that we are going to see that picked up in direct-to-consumer testing. So it's the case that the FDA already has a means of approving direct-to-consumer tests like that. There are already companies that offer direct-to-consumer lab testing, right? They'll come to your house, they will send you to a local lab, they will cut out the traditional role of the clinician as we think about it in terms of ordering tests. And people are going to be able to order their own Alzheimer's disease biomarkers and APOE results and come in then to the clinic. They're going to see people like you to find out more about what these results mean to them. And so, how do we think about communicating that? How do we think about as a healthcare system really absorbing and caring for those individuals? We're already in a situation where there are severe constraints on the availability of specialty memory care, at least at the University of Pennsylvania. I don't know about at UCLA. There are long waits to get into the memory clinic and care for people. And it will be important that people can get care once they have this information about themselves. That said, I don't want to be all doom and gloom. I think sometimes as an ethicist, we have that bad reputation for being sort of professional killjoys. But in this case, I think that having direct consumer testing can be important. It can help people test in the privacy of their own homes when they might not otherwise. I don't think it's going to be terribly dangerous. There were really grim predictions when we had direct consumer HIV testing and even direct consumer pregnancy tests that were put out on the market. Those really didn't, the concerns were not realized. And given the push for patients to have the ability to have access to their health information, this will happen, and we need to think about how as a system we're going to absorb it and address their concerns. Next, we have the space of digital biomarkers, right? So I already signaled that I think that soon Geico will be able to use that the plug and play device in your car to tell you if you're at increased risk for developing cognitive impairment. But what that is now is that, that's your auto insurer. They're not covered by HIPAA in the same way that we think about the health system being covered by HIPAA. So, but this is health information. So we really don't have a sufficient framework right now for how to protect that kind of information. And there will be legal and ethical challenges ahead as we know that we can use that information. And what are the fiduciary responsibilities of, say, your bank if you start bouncing checks, or your auto insurer, if your driving patterns change, to come back to you with that information and share it in a responsible way. And that's really not something that we have good frameworks for. So another area that in conjunction with APOE testing, we're going to have to figure out as a society. We need to think more about living well with Alzheimer's disease. So right now we have an over-reliance on informal caregiving. Oftentimes adult daughters are asked to step into the role of providing care for individuals who had mild cognitive impairment or a dementia level of impairment. And how can we use broader knowledge of people's APOE results, their broader knowledge of their risk of developing dementia, to really advocate for systemic change, to make it better to live with dementia. So, it is the case that we're going to need to have broader advocacy. And I think one of the reasons that Alzheimer's disease is perceived as a fate worse than death is that people really can't envision what it means to live well. And we need to have social systems in place so that they can recognize a beneficial alternative. Now, another thing that we found, and this is in the context of Alzheimer's disease biomarkers and not genes, but people who find out that they're at increased risk for developing dementia, 1 in 5 of them communicates they are interested in medical aid in dying, should they develop cognitive impairment or feel that they're burdening their family members. Now, 2/3 of people say they're not interested in it, but they do indicate they're receptive to it. They say it could be beneficial for some individuals, that it should be an option. So what I take away from this is that we have a constituent group that is interested in aid of dying, or at least open to it. And yet almost to a person, the people we interviewed did not realize that they would not be eligible for aid in dying under current laws. And that's because people who have cognitive impairment are generally not going to be able to satisfy the 2 criteria simultaneously of having capacity to request aid in dying and also being within 6 months of passing away, right? Those 2 are not going to be satisfied simultaneously and they won't be eligible. Now, some states like Oregon have already started to grapple with whether or not aid in dying provisions should be extended to people with neurodegenerative diseases, but we really do need to think about this more. So this brings me to another challenge. What does it mean to die well with Alzheimer's disease? So should we make things like medical aid in dying available to people? Now, those 2 conditions I mentioned of having capacity to request aid in dying, that's been so important for voluntariness, right? We are worried about abuses of people who might be seen as a burden, and family members who might exploit this process to try to either save money or relieve themselves of what they see as a problem. And the less than 6 months to live has been very important because that's to make sure people are eligible for hospice benefits. There's a hope that if people have access to hospice, that maybe they don't need to see death as an escape, but they can die with dignity and they can have relief from pain and all of the benefits associated with receiving hospice. So if we make people with neurodegenerative diseases eligible for aid in dying, we are actually going to really need to think about how we still preserve protections. We don't reduce protections for other vulnerable populations, but feel comfortable with what we're providing to these individuals. So that might be advanced directives. It might be euthanasia, very unlikely in the United States, right? But we can think through a variety of options that would be of interest in this context. So with those challenges behind us, I will just say that if APOE is routinely disclosed in clinical practice, we're going to need to consider the ethical, legal, and social challenges that are involved. Right now, science is accelerating and society is lagging behind. We do not have adequate protections in place for individuals who get this information. We don't have the services and supports that we need. And we really need to try to close that gap between science and policy. Now, of course, the work I presented today is not my own. I have to acknowledge the contributions of this amazing team that I have pictured here, the pen that has helped with all of this. I also want to acknowledge the research participants who have so graciously shared their time and their insights with us. We've learned so much from talking with them. And I'd like to thank all of you. It's really a delight, even if virtually, to be back at UCLA and to have a chance to revisit where it all began. So thank you so much.
Thank you very, very much. As a programming note, we have some time for questions and answers. You feel free to put your questions into the Q&A function, which you'll see it at the bottom of your screen. And now I'm going to hand things over to my colleague and one of our ethics fellows, Joanna Smolensky, who will moderate the Q&A.
Hello, hi everybody. I'm Joanna Smolensky. As Dr. Braddock said, one of the clinical ethics fellows here at UCLA Health. And I will be moderating the Q&A today. So if you're interested, please go ahead and put any questions you might have in the Q&A section. And I thought I might take advantage of this opportunity as the moderator to get things started. So thank you, first of all, Professor Largent, for such an interesting talk. One of the things that I was curious about is you talked about how the revealing of these biomarkers for Alzheimer's is very unlike the revelation of other kinds of diagnoses. But of course, it nevertheless sounds sort of familiar about diagnoses like, let's say, HIV/AIDS that might be very emotionally traumatizing, or where patients might feel like they actually don't have very much that they can do as a result of this diagnosis or to interact with it. So I was just interested if you'd done some comparison studies with Alzheimer's and other kinds of clinical conditions that might be instructive.
Yeah, I think you draw a really apt comparison to HIV. That's a disease that we've thought about a lot in thinking through this because of the stigma. Certainly there are parallels in the direct-to-consumer testing context now that we know. So what's changed there, of course, is that there are now ways of managing that. So it's more of a chronic disease rather than what it initially was, right? Which was really, again, being perceived as a death sentence. So in that case, I think there are some good parallels in terms of the stigma, knowing that if you address stigma, you help people overcome barriers to seeking care. You can help in various ways. We've thought some too about something like Huntington's disease. Of course, we see heritability, but APOE is not like the Huntington's genes in terms of the susceptibility and the risk associated with those. So while there are some parallels, again, things sort of fall apart. But your point's well taken that this is not the only thing that we communicate to people that expresses risk for which there might be limited opportunities to change the risk profile that you have. So when I talk about it being different, I think that really does reflect how people see it. One thing I'll say is that when we've talked with family members, some of them actually say they see this as being less bad than a cancer diagnosis, for example, because while cancer is something that they have right now and they need to address, this is often a future and something they can put off worrying about. So unlike other things, I guess, cuts both ways.
Great, thank you very much for that. And so turning to the Q&A, there are a couple of questions coming from anonymous attendees regarding questions about how genetic testing could be used or might be used by insurance carriers or long-term care, and sort of more generally how insurance might handle test results that aren't fully predictive in this way.
Yeah, so I think that we're going to have a lot of pressure. So the FDA approved label for aducanumab doesn't require amyloid testing, which is surprising because it's supposed to be an anti-amyloid agent, and it doesn't require APOE testing, even though we can stratify risk based on APOE status. But should insurers decide that they're going to cover aducanumab, I think there will be a lot of pressure for both of those tests to also be covered. That's to make sure that if you're going to give a drug that costs $56,000 a year to an individual, you'd like to know that they're a good candidate. So do they have amyloid? And you will also want to know something about their risk so that you can go through a good informed consent process and tell them about the risk. You might change your dosing, your frequency. You might do more scanning, right, to see if they have developed ARIA. And that will be a good push on insurers to offer that kind of APOE testing and cover it for individuals. But I think that you're not going to see insurers covering it until they have a treatment that they're willing to offer to go with it, because otherwise you're communicating risk information in the absence of something that is medically actionable.
Okay, great. We also have a question here from Kim Chen, who asks, Dr. Largent, what are your thoughts on the accessibility of the testing results in the EHR for all other care team members not directly supporting genetic counseling or targeted disease management, which is to say primary care providers and their staff, researchers, etc.?
Yeah, so I think I actually really like the idea of starting with primary care and answering a question like this. So it's often the case that primary care providers describe themselves as maybe not being very comfortable with cognitive testing. They feel like they don't have a lot of time. And if you make something like an APOE result available, it might help it be more salient for them that they need to assess for cognitive impairment. It's something they should be thinking about. I would say, though, that needs to be coupled with other educational efforts to increase comfort, talking about those results with patients, and doing those cognitive assessments that we know they're not comfortable with right now. Obviously, APOE testing sometimes happens in cardiac context, so there might already be some people who have that, or there could be other team members who would have medical reasons for having access to it. So I do think that we would want reasons, right? UCLA knows, as well as any organization, that you need to be careful about who has access to electronic health records and what information they have access to, but that there can be good team-based reasons to have that kind of communication.
And we have another question here from an anonymous attendee. For the lifestyle changes which occurred in both patients and family members following disclosure, were those consistently present in all follow-ups, or was there a decline with more distance from the APOE testing results? And if so, how was that combated?
Yeah, so we saw, right, for people who are interested in the stages of behavior change, we saw some contemplation happening across both groups, people who knew they should be doing something and maybe hadn't gotten ready to make the change. And then there were those individuals who had made changes. I wish that we had more follow-up beyond a year to know how many of those changes stuck. If you really hate fish as much as some of the people talked about, you might not be able to compel yourself to eat it beyond a few weeks or months. So I would say that we need more information to know how durable those changes are with time. The other thing is that because this was qualitative research, we actually don't necessarily know a lot about the direction of the change. And something I worry about in this context is that by telling people that they're not E4 carriers, we might actually suppress changes that they should be making or things they should be doing anyway. So when we see that we have more future planning in people who are at risk, that seems good, right? We'd like to encourage people to get their affairs in order, think about caregiving responsibilities. But people who are not E4 carriers are not off the hook from needing to have an up-to-date will, thinking about an advance directive and end-of-life care wishes. And some of them really told us, like, it just doesn't feel as urgent as it did before. And so I worry, we need to do some research where we can actually make some claims about causation and direction of effects, but that we don't suppress important pre-planning behaviors in people who are not carriers or don't perceive them at risk in this particular way, right? But that's an open question.
Lauren in the Q&A asks, makes reference to some research done by Dr. Dale Bredesen here at UCLA about Alzheimer's and what could maybe be effective as far as prevention and maybe even reversal of earlier Alzheimer's. Do you have any thoughts about his work more generally that you could bring to the discussion?
Yeah, so I'm not as familiar with this work and so don't want to speak to it directly, but I thank you for providing that link in the chat, Lauren. I would say that there's a lot of interest in precision medicine for the brain and trying to figure out what we can do. APOE is obviously just one facet of an individual's risk. We know that social determinants of health play a lot of role here. Education, early education is an important role. Various factors that contribute to the resilience of the brain. And so as we think about precision medicine, we're going to have to take into account all of these facets.
Okay, and now I will turn to one of my colleagues here in the Ethics Center, Dr. Daniel Calise, if you would like to join in with your question.
Yeah, of course. Thanks so much for your talk, Professor Largent. So I have a question that's kind of related to what you talk about as next to friend risk. So basically next friend risk describes the thought that once an individual learns they're a carrier, then family members and friends learn that they may one day need to provide care to a loved one. But I'm kind of more curious in something that you hinted at halfway through the talk about this variant of next friend risk, which we might call like next of kin risk. So can you talk a little bit about the ethics behind informing, say, children of results about genetic markers? And so here I'm interested in not the fact that they may become a caregiver one day, but they may also have that marker. So if a couple were tested and they were both E4 homozygotes, I'm not a geneticist, but I think this would mean that the children would also have that marker. So what kind of obligations might the parents have in such a scenario?
Yeah, so when we talked about sharing and we asked people, 98% of our participants had shared their APOE result with family members. And while there were many reasons for this, like good relational quality between them, or you're more likely to share with somebody like your spouse that you talk to and maybe feel like you don't have secrets in your relationship, whereas the brother you're estranged from is not somebody you're going to share with. You don't reach out to let them know about that. A lot of people did share with adult children because they worried and they wanted those children to be tested. Now, what people do with that information is an open question. There were a number of people who were, adult children who said they weren't ready, right? Maybe they were still in middle age and they were just like, it's not something I'm ready to learn yet. And certainly people worried also about grandchildren, but they talked about how inappropriate it would be to tell a child or somebody who is still that early in life, like they felt like it was premature for them to worry about it. So, I think that giving people an opportunity to learn once you have that own information is important, but people are going to decide for themselves what they want to do with it. And again, right, points of friction in families, I think this information can create ripple effects throughout the systems because not everybody wants to know. Some people are just too scared of that information.
One maybe more technical question here coming from the Q&A, asking what is the status of use of Roche's ELISIS immunoassays or blood test in measuring tau, beta amyloid, and predicting APOE genotype? Is this something that you're familiar with, Dr. Largent? Yeah,
so in terms of the blood tests, I would say there's a huge amount of interest in these blood-based biomarkers. All of the tests that I'm aware of, there are some exceptions that I won't get into on the call, but most of these are still being validated. And while I'd say there are very, very promising early results and a thought that this will they will soon be available, they are not available for widespread use yet. So still in progress.
Pauline Wu is asking, who oversees the ethical issues of private direct-to-consumer companies like 23andMe, as you mentioned during your talk, and the recent announcement to use genetic data to develop drugs?
So 23andMe controls what they do and what their ethics are, which of course is of concern to many ethicists because it's not always clear that what they're doing is what we would all agree is best practice, to the extent there is agreement amongst ethicists, right? I feel like so much of ethics is fun because reasonable people can disagree. That being said, 23andMe, I think they've been clear really for a very long time that their main money-making strategy is not actually telling you whether or not you have sticky earwax or whether or not cilantro tastes like soap when you eat it, or even that you have an APOE E4 allele. It really always has been a plan to try to help people get access to these larger data sets to do things like developing drugs. I think that's a much more viable business model for them in the long run. And they've been clear in their consumer agreements that that is something they are interested in doing. You can choose to opt out of it if you click through enough screens. But that's a business decision that they're making because of the nature of the contract with the customer that they have created.
We also have a question from actually quite early in your talk. You spoke primarily about APOE E4 and how that might be associated with risk, but you did make mention of how APOE E2 could potentially be associated with protection from Alzheimer's. Could you say a little bit more about what that protection might involve?
Yeah, so that's quite rare, and I'm not sure about the mechanism by which it does it, but those individuals do appear to have risk that's even lower than the population average. So we talk about it in terms of being protective.
So Professor Largent, Emily, if I may call you that.
Please do.
The last time I remember you were in Scrubs and you were in the CTICU tending some of our sickest cardiothoracic patients. Can you speak a little bit about whence your interest in the ethics of cognitive disorders and in particular dementia? What has brought you into reflecting and writing about that field?
Yeah, so, being a nurse was just so important, and I really love taking care of patients, particularly at the end of life. And I found that to be just a great experience. I loved working with the ethics consult team when they came in not infrequently to work with the patients that I was caring for. But what I found over time is that I felt like I was seeing patterns where I would solve a problem, in one patient's family, and then I would have the problem with the next patient and the next patient. And so I really came to feel like what we were seeing were systemic problems that as a bedside nurse, I could solve in this one-off fashion. And it was really gratifying to do. And I can still close my eyes and picture those patients that I took care of and often think of them actually in the work I do now. But I felt like what we needed to have was not just this one-off resolution, but really systemic change. And that's what sent me off to law school and to study health policy, to think about how we can take these bedside events and really create better structures of care. And in all of that, I was very interested in vulnerability. I was interested in decision-making, surrogate decision-making, which comes up so often at the bedside. And I would say so many of these issues arise in the context of cognitive impairment and dementia. And so this felt like a really natural extension of many of the questions that I had that first started at UCLA, where I wanted to think about how do we take care of these very vulnerable patients, make good decisions for them, and really provide optimal care.
So thank you for a phenomenal lecture. At this time of the year, when we are all thinking with the holidays on the horizon of going home, in my case, home for the first time in 2.5 years because of the pandemic, thank you for coming home to UCLA, to us. And it would be wrong of us to leave without, of course, thanking Tom and Leslie Weinberger for their long-standing and generous support of ethics in general and of UCLA's Ethics Center in particular, which includes, but is not limited to, the sponsorship of this annual genetics lecture. So a very warm and heartfelt thanks to Emily, to Tom, and to Leslie. And thank you all for joining us and participating.
Thank you.